Our speaker today is Dr. Killett. Dr. Killett has been researching social care and older adults since 2008. Coming from a career as an occupational therapist, she's passionate about active involvement influencing research of those who are most affected by the research. Her latest funding acknowledges this with an award from the UK's National Institute for Health and Care Research to study the public involvement role in research of older adults living in care homes. Research with care homes and their residents and workforce should model respectful, inclusive, personalized relationship essential for good care. This is a recorded seminar, and a video of the seminar introducing Dr. Killett and her presentation will be made available online. Welcome, Anne. We're thrilled to have you join us.
Thank you very much, and I'm very, very pleased to be here and joining you this afternoon. And that looks good, thank you. So, yeah, happy to go onto the second page. Thank you. So, as Peggy kindly introduced me, I started out as an occupational therapist in practice, and then I've been in academia and researching for quite some time, building on that. So my career in research started while I was in practice, doing first a master's and then a doctorate. And I was working at the time with children and adolescents at the other end of the age span, and it really struck me that I got so much out of the research activity. It was so stimulating and interesting, and it feels good, doesn't it? And it's got, people are really interested in what you're doing. And then I was thinking, and the people we're researching, maybe not so much. So how can they kind of get something out of this as well? So I became, and also, I guess, particularly with certain groups of people, and I think older people and perhaps younger people have this in common, children have this in common, they tend to be quite done to in services. So I got very interested in active engagement in research, and thinking about occupation as an occupational therapist, we think of human activity, then we think about the qualities of occupation and that the things that we do have meaning and give meaning to our lives. But also we think about grading. We can have too little to do, we can have too much to do. The things that we're asked to do can be too demanding for us or just the right amount of challenge. And so we think also about balance. And so I was very interested to think of research as an occupation and thinking, how can I collaborate in this occupation with others so that they can also be getting something out of it. Thanks, Peggy. So on to the next slide. And this has chimed very much over the past decade, I'm sure, in Canada as well as in the UK and other places. There's been a great emphasis put on public involvement in research, and our National Institute of Health and Care Research defines this as public involvement in research that's done with or by the public, not to or about them, and that people who have relevant experience contribute to how research is designed and conducted and disseminated. But as soon as you look at that definition, it strikes you that, of course, people are likely to be involved in many ways and in research, and it's sometimes not always, sometimes the different roles can blend or merge. But for research about care homes, the public who've got the relevant experience there, the public who are at the heart of that are clearly the people living in the care homes, while there is a whole range of stakeholders around them who also have a legitimate interest. Family members, people running care homes, are stakeholders. But if we look at the study of public involvement, there's been there's an interesting sort of critique in a way that I started out studying participatory research when I was first interested in it, and that has its roots back in education and in empowerment. People like Paulo Freire in Brazil, when they were resisting sort of colonization, really, and people are critiquing that while it's good that there's so much emphasis that there should be public involvement in research, if we go too far down the route of sort of bureaucratizing it and systemizing it, sometimes we do that at the cost of potential for empowerment. And so we get people critiquing the idea that public involvement has to be there, then it has to be evaluated, and then we start evaluating it as if it's an intervention, whereas we should be looking at people, at the public, as our partners, not someone who are receiving an intervention. Thanks, Peggy. I'm going to talk quite a lot about the public involvement we evolved with the Dacha study, and that's funded by the National Institute of Health Research. It's led by my colleague on the right there, Claire Goodman, based at the University of Hertfordshire. And it's developing research resources and a minimum data set for care homes adoption and use. And I have to say, in the yellow box at the bottom, the UK context is that they're currently, unlike Canada, USA, New Zealand, there isn't systematic data collection and synthesis of the data that's collected in UK care homes. People tried to implement, they tried a project trying out whether they could implement Inter-RI, which is what I believe is many people will be familiar with in the UK. But even with the additional resources that they brought into a research project, they found that they couldn't implement it. That was sort of back in 2008 time. So in the Dacha study, we're aiming to develop and pilot a minimum data set for care homes that works in the UK, that's underpinned by public involvement, stakeholder engagement, and is really building on the best practice and existing evidence internationally. And that really does capture the needs of those living in care homes, the outcomes that matter to residents, and it can combine care home administrative and NHS data to reduce the demands that are put on care homes, because they're very much serving a kind of beast that requires loads and loads of data. So that's for monitoring purposes, for funding purposes, but very often not hearing much back from the data that they provide. Next slide, thanks, Peggy. So Claire and the whole team, the whole of us as a team of co-applicants from the start were really prioritising the fact that we wanted to work with important stakeholders. And as soon as we began to do that, and we began to try and discuss amongst ourselves as a large team of collaborators and with stakeholders, we realised that there were very shifting understandings, slightly, overlapping but slightly different understandings of what we might be meaning and aiming for an MDS, particularly when we talked to the stakeholders. And really they encouraged us and sort of pushed back to us to say, well, you really need to get your core principles sorted out. And so we worked on this, and this is from something that we got published in the Lancet Healthy Longevity journal as a sort of personal view. And it was really helpful that we got that push from our stakeholders to be explicit and agree amongst all of us what the core principles should be. So we started with the principle that we would focus on what matters most to support those living in care homes. That this would be evidence-based, but also co-produced. That we really wanted that it was important that this reduced the data burden for care homes to free up time to come back into direct care. this certainly would never fly. It will never be implemented if it, it ends up being a greater additional burden. We were at the point in the UK where digital care records were coming in, but there still were a lot of care homes using paper-based records, and we thought we cannot go down that route. This has to be something that's ready for the digital, rollout. And since we started the project, that is something that's been mandated by the government. And we wanted to bring together data on residents, but also service level data and workforce data in care homes, and also bring together data sets from the care homes themselves, but also other sources, typically the National Health Service at different levels. That all of this data, if there's going to be data sharing, it needs to be underpinned by really careful agreements that protect people's rights, privacy rights, that care homes are going to need support to really use the data they collect and be able to have access to dashboards so that they can both, they can use sort of collated data as well as simply just provide it. And it needs to, it's going to need national infrastructure and integration with existing data systems. Thanks, Peggy. So, of course, loads of potential for an MDS to implement in England and the UK. There's the potential of having better information pulled together around the person being cared for to really, make that much more accessible and in real time, but also the potential for use in quality reporting. But what we're aware of there in the system in the UK, with lots of different providers, mainly in the private sector, that there are sensitivities around that. There are market sensitivities around that, and we had some bad experiences over COVID. I'm sure you had similar in Canada, where certain care homes information about perhaps death rates or infection rates got into the media, and individual care homes sort of castigated in really, really unhelpful ways. So there's, we realise there's a responsibility about getting this right. And of course, what's collected and assessed becomes the focus of everybody's efforts and resources. And so it really needs to be the important things, the things that are really at the heart of care, so that we don't get unintended consequences of effort going into unhelpful areas. So thanks, Peggy. So then, from my role in this project was leading the public involvement. So for me, how can we keep residents' voices at the heart of what is a really complex project? Next slide, please, Peggy. So this is a quick look at the project. We wanted to get a visual quite early on so that we could kind of communicate what was going on in the project. So from left to right is over time. It was a 4-year project, but we're currently in a 6-month no-cost extension, and we'll finish in April. So as is typical with projects, we've got the early months where we've got work packages that are really doing quite a lot of reviewing. So we were looking at existing outcome measures that were being used. We were looking at whether we could bring together data that from randomized controlled trials that have already been conducted in care homes, so that that data could be aggregated and used to answer research questions. And that repository is now up and running, and new trials are reporting into it. We had reviews of how minimum data sets are being implemented in other countries, and how what they contained and how they were being used. And then we worked in work package 4 with a charity in the United Kingdom called the Health Foundation, who do an enormous amount of work around, really sophisticated work around data systems, large data, and sharing that. And so they worked really carefully on how we could get agreements, and we tried this in 3 regions of England, where they worked out agreements between the local authority, care homes, and the NHS to share data. And then finally, the stage that we're in now, the work package where we've developed a trial MDS, and we're trying it out. And although it says 2 integrated care systems there, such was the interest in this from our NIHR that they readily gave us an additional bit of funding, an additional sort of bolt-on project, so that we could go to 3 integrated care systems. And those are the sort of organisational levels at sort of county. They'd be around a county level where there are commissioners responsible for commissioning across health and social care in an integrated way. So then that's the sort of stage that we're at, with taking the data from and seeing how the minimum data set has worked for people in those pilots. And you can see that along on the left hand side, our patient and public involvement has been sort of coming out, going along with all of that activity. Thank you. Next slide. So our challenges and principles that we had varied stakeholder groups, and we decided from the start that we'd engage with them in different ways. And we were aware that for certainly people living in care homes, quite a lot of care home staff and family members, then this study subject is actually quite technical, quite obscure. And so we were very keen to develop good trusting relationships, communication, and try and have a shared understanding, so that people are in the best possible position to be able to be really contributing their experiences, their priorities, their perspectives in trying to shape this project. So we had a definition of public involvement, which was listening to the voices of individuals living, dying, visiting, and working in care homes, members of the public, and other key stakeholders in health and social care system, in order to inform the quality of the research and enhance the usefulness of the study findings. Thanks, Peggy. As I say, we had different ways of doing this. We were going to be working in 2 groups based in care homes with residents. Then we had a panel that met quarterly for care home staff, managers, and family carers, and then national expert consultation groups that met 3 times over the period of the study. But I'm going to concentrate today on talking about the work with residents. Thanks, Peggy. We supported all this work with co-applicants in our PPI team. So as I say, I led the PPI work. We had another academic researcher and a senior manager from a charity that advocates for not-for-profit care homes, and those co-applicants together, we supported, with our senior research associate, we supported the public involvement groups, but we also acted as the sort of the glue and the go-between, really, between the rest of the research project and the public involvement. And we supported work package leads so that they could develop materials that were really meaningful and accessible to the various PPI discussions that we were having, and then helped the researchers to interpret what was coming back and feed that back into the project. Thank you. So as I say, it was about trusting relationships, using perhaps examples, short cases or stories, giving people back quite quickly some short accessible notes on what had been happening, listening very actively, using pictures, and translating the terms and very carefully that we were all using. Thanks very much. So I'd done some earlier work before we got into the Datcha study, where we researched people's interest in being involved as residents, as members of the public, informing research. And so we very much drew on the principles that came from that work. Thanks very much. So what we understood from that was that people living in care homes, some people were very much interested in public involvement roles, that we had thought they might want to meet outside the care home, but on the whole, people found, people, as you are aware, would tend to be living with quite a level of frailty or ill health, and find it quite effortful to leave the care home. And for these sorts of purposes, they were just as happy, most people were just as happy that people would go in and meet them. And also, they really appreciated the kind of gatekeeping role of their manager. If the care home manager sort of checked people out as like us and said, yeah, they seem okay people, then older residents kind of welcomed that. So, and learning from our previous study, we planned to have a group of residents that we'd meet regularly. They could get to understand the study, get to know us, we'd get to know them, we could facilitate discussions at various points and bring their input into the study. And we thought we'd do this in 2 different care homes, so we'd have 2 separate groups, and that this would give breadth to people's opinions and views. But COVID-19 came along and prevented us taking that forward. Next slide, please. So one of our co-applicants was a daughter, a family carer, and she had spent quite a lot of time in care homes. And she said, well, that surely even now in COVID, she said, the activity providers will still be working with the residents. She said, why don't we try and get in touch with activity providers and see if they would run some public involvement activities for us. And the challenge we'd been having was that care homes were so busy that we had 2 care homes who were happy before COVID. They were really keen to run these 2 resident groups. But once COVID struck, we couldn't raise them. We couldn't hear back from them. And that was because they were so overwhelmed with trying to deal with COVID, look after their residents, look after their staff, deal with all the rapidly changing policy directives that were coming. And interestingly enough, while we're talking of data, there was masses of data that they had to supply. Suddenly had to talk about their bed vacancies. They had to talk about weekly and daily sort of vacancies, infection rates, and basic observations on their residents. Suddenly they had to give all this data. So they were enormously, overburdened. So we thought, well, we can't get to the activity providers in the homes that we were going to work with. So we linked up with a national association that supported activity providers, and they were really happy to work with us. And through their network, they were able to reach out to, they meet activity providers regularly, and they were able to meet some and invite them to take part in this study. So with this way of working, activity providers were working with residents kind of with a new involvement activity about every couple or 3 months. And we were able to get that regular input of residents' voices into our project. We found that the residents were really positive about being asked for their views in this way. And the activity providers were incredibly enthusiastic, really, really thorough. And, there were some interesting impacts on their care homes for working in this way. So thanks, Peggy. So, as I say, we worked with this national organisation, And although we were doing public involvement, and so ethical review was not essential, but our faculty research ethics committee agreed that they would do an advisory review for us, as it was a potentially vulnerable population. So they reviewed it and gave us a positive review on what we were planning to do. And we found that there was an enormous amount of interest in the process from care homes and from other researchers. And I suppose just activity providers, by that word I'm meaning the people who are employed by care homes to plan and facilitate meaningful activities with residents that will support their mental and physical well-being. Sometimes they're called activity providers, sometimes well-being lead, sometimes activity coordinator. I have to say, not all care homes employ an activity provider. Some see it as important that actually facilitating meaningful activities should be a shared role across all care staff. Thanks, Peggy. So this is the process that we went through. Preparation of an activity, a public involvement activity, then facilitation, and then evaluation. And the preparation involved us as researchers meeting with the activity providers who'd agreed to work with us. And we had a rough idea of what we wanted to talk to residents about and what sorts of activities might facilitate that. And then we wanted their involvement, to their feedback really on whether those activities would fly with the residents, because of course they know them so much better. And we got feedback early on that they wanted a pack, they wanted a kit, they wanted something that they could just go to and sort of open it up and run it. Having said that, of course, they knew what was in it because they were part of developing it each time. So we had an activity kit, and although they were similar for each topic, they did change because we wanted to talk about different things at different stages of the project. And this is something I think that perhaps we haven't always been clear about, because when people have been really excited about doing this work, they've said to us, other researchers have said to us, can you send us your activity pack so we can do our public involvement? It's like, well, no, because the pack's about our study and the particular questions in the study. So then the facilitation, the activity providers introduced the topic and the activity kit to residents. And the activity providers we first worked with, we said, well, how is it best to introduce the project to your residents? And they asked for a little video clip, and so I did a little explanation, and they played that on a sort of TV screen, I think. So then they would deliver they would facilitate the activities, and they were very good at tailoring things to the needs and preferences of the residents. They'd then make notes after the session and then come and meet us online for a debrief session. The support manager from NAPA was there as well to offer them support. But then we'd get back from them the feedback from residents, and we'd be able to take that back into the wider project. Thanks very much, Peggy. So far, and we're just finishing, and we've got one more topic we're just running at the moment. We've completed public involvement activities with residents for 7 topics. And for each topic, we've had 2 or 3 activity providers, each in different care homes. That has evolved slightly. That isn't the same activity providers we started with. And I think you'll all be familiar with how people either, some of the people have got promotion, some of them have left, gone into other industries, 1 or 2 have become overburdened by situations in the care home. But then we've been able to recruit more, and so we've had a constant sort of 2 or 3 activity providers. And then the numbers of residents that they've then talked to has been between 14 and 54 for each of the topics. And those are some of the topics there information sharing, information for care plans, what's the priority for residents, what do they find most sensitive, which sources, you know, if you could get the same information from a member of care staff, a member of family, your GP, which source would be the most accurate, did they think? Quality of life was another topic, and important questions that could be answered once we had this data linkage. What's important for health and well-being? So thanks, Peggy. I'll go on and talk a little bit more and give a bit more examples. So the activity packs tended to include icebreakers, quizzes, scenarios, prompt cards, perhaps sorting cards and priorities. And then what we found was we developed these with each time with the activity providers, but then beyond that, the activity providers then tailored things for individual residents. Then activities were incorporated sometimes into a pre-existing group. They might have a current affairs group or a discussion group, but other times they would create a special session, plan a formal session, or else a one-to-one discussion. Thanks, Peggy. So this is an example of some things copied out of one of the activities. This is the one looking at quality of life. So we gave a scenario, said a little bit about this person who was created. This wasn't a real person, and we were clear about that. And then we wanted people to talk about whether they thought this person was having a good day, why they thought that, what things would have an impact on the day. And then, as you can imagine, people may need more or less support to have a conversation like this. And so we had prompt cards, yes, no, you know, these prompt cards could be used simply as a discussion, or people could sort them, or people could put the yes and the no against some of the cards. So it was we were very much trying to aim it at a wide kind of needs for support and abilities, and help the activity providers to tailor the work. Thanks very much. And then equally, there were some people who would have a discussion really not needing too much prompting at all, and some people in one care home were quite familiar with working with commercial people, came into the home apparently and asked them for kind of product advice and things. They were quite used to sort of consumer surveys and being involved in that sort of activity, and so they wanted quite a formal survey, which we were really surprised about. We didn't expect that, so we developed sort of accessible surveys, and for some topics those worked and were used. Thanks very much, Peggy. So this I just wanted to share because these people were publicly open about their involvement in the study and their contribution to the public involvement, and they really, we didn't ask for this level of feedback. We were happy to have feedback in a discussion, but you can see the lengths that this activity provider went to in really putting together some professional results. If you go on to the next page, they put a presentation together and they told us how they gathered the information. They used the survey, they used art, crafts and collage, and that they also talked to their staff team about the scenario in the toolkit. Thanks very much. Next slide. And they put together the results from the survey, and all of the questions were put together like this, to show the residents' responses. And we can see there, for example, how much spending time with family, we wouldn't be surprised to see that that's very important or important to most people. Okay, thank you, Peggy. So their perspectives on the activity, on being publicly being involved as members of the public. We were told by activity providers that they felt that their residents really felt valued. They felt very sort of present in the activities, very involved and listened to. And the activity providers saw as evidence of this that people were very confident to contribute, and very willing to engage. The activity providers saying, I didn't have to force anything, people were happy to speak up. And then what the activity providers told us as well was that they really found it helpful that these sessions gave a forum for residents to talk about elements of their lives or elements of care that actually they wouldn't have thought of talking to them about in this, I suppose they might talk individually over their case plan, but to talk in principle about care planning, about data, about information, about this sort of thing, that they wouldn't have thought of talking about it, and a lot came out of it. And of course, this was demanding for the activity providers, because if you hear and you properly listen to people, it's okay for them, in a sense, the stuff that they're feeding back to us, but inevitably they heard things that are very relevant to care on the ground. And so they then have a responsibility to act on that, take that to managers, or maybe make some changes themselves, things that are within their power. So examples of changes that came from this was people talking about wanting to see their care plan and go through the review of it more frequently. And so one care home increased the frequency of care plan reviews with residents actively involved. In another care home, people talked about one of the things that was important to them was having more information more frequently about their healthcare appointments. What did come from it? What was the medication change? When's the next appointment? And so they realised that they needed to communicate that information much better with their residents. Next slide, please. So then the activity providers' perspectives, they found that this really kind of added life to sessions. I think that they really enjoyed, they spend a lot of time thinking and creating activities. And I think for them, it was quite a novelty having someone else kind of create some activities. And I think it was interesting for them to be part of this larger project. They felt that the topics were very valuable and relevant, and that taking part in the project for them was an opportunity to get skills, to develop themselves, also to get new insights into residents' perspectives, and to try new ways of doing activities. But of course, there was the potential for hearing upsetting things from residents, and at times there were things that sort of were quite stirring for activity providers and that they needed to respond to. And that was where it's so helpful doing this within the partnership with the professional organisation, who could offer their support manager as part of this project. And we were, very, very much offering the debriefing. Thanks, Peggy. So from the research team, we were able to get feedback, which helped us to prioritise the types of data that residents thought were important. And in particular, an example of this was we were looking at early on at sort of prioritising different sources of data. And it was felt we touched on getting data from district nurses and community allied health professionals. These are people, because in the care home context in the United Kingdom, there are quite a number of care homes that don't have registered nurses working as part of the team, so that any nursing support comes from NHS community services. And so we'd heard from residents how important this link was for them, and that they wanted this data to be part of a minimum data set. And so its priority went up in our development of MDSs. It became, unfortunately, quite challenging when we were doing the data linkage because of the complexities of the different organisations providing health services, but certainly that was something that we tried to push forward on. In a lot of occasions, you wouldn't be surprised to know that residents' views were consistent with other stakeholders, and in this area in particular, of the importance of quality of care-related quality of life data, of the importance of mental well-being, mental health, as well as physical health being captured very thoroughly in a minimum data set. And this push from our stakeholders really prompted quite a lot of work by the team to look at potential outcome measures around quality of life that could be used and completed, in a timely way within the care home. Of course, we were also interested where we got divergent perspectives. For example, we went to the residents when the Health Foundation, who were the people who were doing the data linkage, was saying, okay, so now we can link these data sets, then we get potential to answer, to do comparisons and make, answer a whole range of questions. What are your priorities? So what residents prioritised was a topic that was really close to their hearts. Was they thought we should be researching, when we had the opportunity, into the impact of hospital admissions on residents' health and function and well-being. And of course, once you can connect databases, then or data sources, then there is potential to research that. And meanwhile, providers and families, for them, they were emphasising, well, it's going to be really important to be able to make comparisons between care homes, see how care homes are doing, that would also be helpful at the point of looking for care homes before someone's admitted to one. Thanks very much, Peggy. So then we're getting towards the end of this work, and is this a good way to involve care home residents in research? And so we thought, well, let's try and find out, actually. We've heard good things, but people tend to be polite, don't they, if they've been involved and they're passionate about it themselves. So we actually developed a project and got funded by a branch of the NIHR focusing on social care studies. And next study, please. No, I'm sorry, next slide, please. So we're funded for 18 months to investigate this way of doing public involvement. And so we've got ourselves the research question: if activity providers facilitate public involvement activities, what's this like for residents? Is it meaningful? Is it enjoyable? What's it like for research? Can research projects change in response to residents' input? Thanks, Peggy. And so we're doing that mainly ethnographically. We've got 3 research projects, one of which is Thatcher and the other 2 I'll talk about in a minute. Then for each of those 3 research projects, we're going to work with 3 activity providers in care homes and do this process that I've described to you already, but this time actually have a researcher going out to observe what happens and talk to residents about what they think has been going on, and talk to activity providers about how they're finding it, talk to a small number of residents and care staff to think about any untoward impact on the care home, but also talk to researchers and try and track if and how the input from residents is having an effect on the studies. So mainly an ethnographic approach. And now, of course, the complexity of doing this is that the people who are involved are both doing public involvement, so they're involved as members of the public, but if we want to observe them and if we want to interview them, they are then research participants as well. So for this, we did go for Health Research Authority research ethics approval, and we were given that approval, and they were very positive about the project. They were very positive that we weren't excluding people on the basis of mental capacity. That seemed important to us because we wanted the potential to see if people who perhaps struggling with capacity could still be involved in some way and what that might look like. Thanks very much. So in this CHAPI study, we're linking with 3 other studies. DATCHA I've talked about, TIMES I'll just say a little bit about on the next couple of slides, and PREACH, I told you earlier that we've developed a virtual archive of lots of data from different care home trials, and that archive continues to grow. And so we have one of our co-applicants has got some further funding to do a priority setting exercise with people living in care homes to see what they would prioritise as research topics. They'll be doing it with other stakeholder groups as well, but as that's part of what that will give us a chance to research again the public involvement. So thanks, Peggy. So the TIMES study is again a National Institute of Health and Care Research funded project. It's led by Professor Chris Fox at the University of Exeter in England, and is again a big collaborative project, and it's aiming at developing a tailored intervention to address sleep problems for people living with dementia. And as we know, sleep can make it much more difficult for people if they have dementia. It can make it more difficult for carers to cope, and it's not straightforward. Sometimes medications work, but they may not be advisable in the long term, and there are a whole range of non-pharmaceutical interventions now in sleep. So this is premised on doctors, patients and carers working together to get the best care for each individual patient, and therefore we're developing a tool to support doctors to do that. Thanks very much, Peggy. So again, quite a complex project with a series of work packages. This project taking part over 5 years, and we're at the end of coming to the end of the second year now, and we're at the stage where the intervention is about to be tried out in feasibility. Thanks very much. But again, public involvement seen as really, really important, and some of the challenges here is, thinking of people with cognitive impairment and how they can be best involved. So again, we have a quite a mixed approach here. I'm involved in this public involvement, but not leading it other than the care home residents part of it. So we have a lived experience advisory forum, which is made up of people living with dementia and people supporting family members with dementia. And with negotiation, they've decided to meet separately. They meet one after the other, and they meet and have the same agenda, in a sense, the same topic, but they prefer to talk separately because of the different needs for listening and taking time. Each of those is chaired by either a person with dementia or a family carer. George Rook, who is a co-applicant and been involved in developing the project from the beginning, and a family carer, Anne Irvine. And they in turn are supported by advocate groups. So we've got Innovations in Dementia, who work with and support the UK network of Dementia Voices, which is very much a dementia-led organisation, and Together in Dementia Every Day, a charity that supports family carers. So they're able to support the people attending the meetings just before the meeting, go through the agenda, help people think about what they might want to contribute, and then afterwards as well, a sort of debrief. This has all been costed into the project. So these LEAFs meetings meet 3 monthly, but people wanted a bit more frequent contact, a little bit of support, to know they felt they would forget and lose touch with the project. So they have a drop-in support meeting just to hear and remember the kind of project members and hear what's happening in the project in between times. And then in terms of reaching out to groups that might not necessarily easily trust and get involved in public involvement activities, we've specifically reached out to a Southeast Asian group with the support of Chinese Wellbeing, which is an organisation based in Liverpool in England and working has some dementia support work as part of their work. So they found it, we were meeting online, but they struggled with that. And so there's actually been some face-to-face meetings there, and those meetings involve translators. So bringing in all sorts of different perspectives and the sorts of things there where people were really, from the Chinese group, were really struggling to get GP appointments, never mind kind of get to the topic they wanted to with GPs, and telling us about some of the traditional approaches that they also valued in relation to sleep. So, and finally, what I'll be leading on this is working with people living in care homes, because they're not excluded from this involvement. They still get their health care from general practitioners, and so they, just as much as anyone, need a tailored approach if they are struggling with sleep. But of course, there are all the additional challenges of that. And what we've learned from Dacha and working with residents is that sometimes the residents themselves don't feel that they get that proper information back from their appointments. So that's going to be a really interesting process to facilitate some public involvement around sleep. And the activity providers have been really enthusiastic to work with this project, because they say sleep's a biggie. You know, they find themselves talking to people a lot about sleep. So I'm very much looking forward to that next stage. Thanks very much. Next slide. And what I would say about our team at Chappie is very much a collaboration, and I've led the development of the project and getting it funded, and it's been really important to me that this should be a shared endeavour between practitioners and researchers. And so the practitioners are co-applicants as well, even though this has been challenging sometimes in making they might be working for private companies, and how does that kind of funding work with like a public body like NIHR that is really just set up to work easily with higher education institutions. So we've got a care home manager as one of the co-applicants, and she has been excellent in sharing her knowledge and really sensitizing us to the care home context. You know, she pulls no punches and talks about the crisis that social care is in, that the pandemic has an ongoing impact now. Okay, you know, there's much less infections, although some again in the winter, but suddenly they'd been in these particular kind of conditions for the pandemic, which involved a change of expectations. There weren't so many inspections and things, but when suddenly it was deemed, oh, we're all out of this, care homes were actually still dealing with the trauma. They still had, staff members who'd become quite ill and were long-term affected, and then suddenly to switch back to normal expectations on them was really, really difficult, and continues to be so. And she got us thinking much more broadly and creatively about what research can offer to care homes. Yes, we think of vouchers, we think of trying to reimburse people for their time, but equally, she said, we should think about, care homes are commercial enterprises, they need a good name, they like to have good, positive stories out in the media. So can we work with care homes to help them have articles for newspapers about their involvement. Can we link in with the Care Quality Commission key lines of inquiry so that care homes can use their participation in research as evidence of being engaged in sort of civic society and being engaged in improvement endeavours and adding to knowledge. Thanks, Peggy. In return, the practice members of the team wanted to learn about research, and what was that, we said, okay, we're happy to talk about research. What sorts of things did you want to know about, and what makes it meaningful to you? So they pushed us on some difficult questions. How do people get to be researchers? Well, one thing all sorts of ways, you'll know that, and we'll come. There's people in our team who are interested to become researchers, practice researchers, and are on that journey, which is really exciting. They really pushed us. I mean, isn't this an important question? What happens to research when it's completed, and how can we find it? Really good question, and surprisingly complex and unstraightforward. There had been a really good repository run by a charity in the UK that was aimed at care homes, aimed at social care more broadly, and really collated social care research. But that's now archived and it's no longer live. So we could do with having something again like that, really. And the $10 million question: how does research make a change? And our aims in learning together with this is about breaking down myths and building people's confidence. Finding, again, everyday ways and shared understandings to talk about what exactly research is, and demystifying it, really. Thank you. So our progress in CHAPI, it's not quite where it should be, which is frightening. One of the things for me, it's great working in collaboration, but however much time we thought we needed, it's always more, it's so time consuming to work well together. But anyway, we've got 8 out of our 9 activity providers recruited. We've got observations and interviews already carried out of public involvement in 2 care homes. We've been updating a literature review on public involvement of care home residents, and there are still very few examples of residents actually being involved in the public involvement rather than having sort of proxy involvement. And we're also doing a scoping review on the role and work context of activity providers. It's really important. One of NAPA's really important aims is to get value to the role of get recognition and value for the role of activity providers, and we want to have an output if people want, which we know researchers are keen to use this method. We want to have a sort of how-to guide, but we need to set that in the realistic context of the work setting, hence our scoping review. But as I say, there are other things, unexpected benefits, and our co-applicant Marlene was recently awarded a fellowship 1 day a week by the NIHR to develop, so where she's funded by them to spend a day a week getting some structured teaching and learning about research skills, but also undertaking a project in her setting. So that's really exciting for her development as a social care senior practitioner researcher, and I think that's the way forward. We need people to be, confidently thinking about evidence and using evidence, but absolutely actively involved in developing evidence to get really good research into social care. Thanks very much. Next slide. So I suppose my conclusions that research, I think it's important to think about research as a meaningful activity that we can be engaged in, and that research in its processes can have so many impacts, and therefore we should be researching in ways that that kind of represent the best of what relations should be like in care. Research can be a meaningful activity for individuals, but also for organisations and for society as a whole. I think we need to be open to differing and contradictory perspectives and really think about how we manage those and how we manage sort of power relations within involvement work, where stakeholder groups do have different voices, and individuals have different levels of power and different voices, and how do we manage that? I think we need to keep challenging any boundaries of public involvement. That might be about groups who are not often included, and you know, where extra work is needed to develop people's confidence in us as researchers in even the kind of public institutions. And we need to be really alert to boundaries, and sort of shared endeavour between things like activities like research, activities of learning, activities of improvement. And in terms of working together in research, in collaborative research, then we need to think about sustaining relationships over time with care providers, with families using care, with care home residents, and think about how we can each sort of contribute to that and adapt systems, the systems that we're part of, so that it's easy for people to become part of research activity, to become part of you know, the whole research practice endeavour. So that sort of that brings me to the end of my presentation. I don't know if you want to quickly flick through the last slide, if you don't mind, Peggy, because there's the usual acknowledgements of wide ranges of people and disclaimers from that the NIHR find important for us to show that these are my views. They're not necessarily the views of the NIHR or the Department of Health and Social Care. Thanks very much.